you very much, everyone, for participating in this webinar. We're very excited to have Brian Roberts here to talk about concussion, and it's lovely to be able to get an international speaker of your calibre, Brian, to be able to engage with us and share the knowledge that you have and your expertise in concussion management. Most people know Brian from the invitation that was sent out, but you've had an extensive amount of involvement in sports, exercise physiology, and also concussion management. So I'm very thrilled that you're able to join us, and just really looking forward to your talk and sharing your information. So we plan for this webinar to probably go for about 45 minutes and then have questions at the end. And then Perfect. This is part one, and then next week we'll do part two, where we have Elizabeth joining us. Elizabeth is an OT, and she will talk about therapy and her involvement with these patients. So I'm going to share my screen and I'll bring up the presentation, and then we can start. So, Brian, do you want to just start with this one, and I'll play the video. And what we thought we would do is just put in a video just to give you a feel of what the SMARTfit product is prior to Brian starting. So that video gives you a nice overview of what we're talking about in terms of the SMARTfit. I've stopped sharing now, Brian, and you can share your screen and proceed into the talk.
Thank you.
We do have a question box there, or a chat box. If anyone has any questions, just feel free to pop it into the question box, and then we'll bring up these at a later date, answer the questions at the end.
Great. I'm always happy to answer questions, so I hope we get time to do that.
Mm-hmm.
Thanks so much, Bev, for inviting me to speak. Good morning, everybody. I'm talking to you from Long Beach, California, so I'm excited about being here with you and sharing some information. I'm very passionate about concussion and concussion services. Bev and I were talking before this that we're at a really unique time in our industry, and that the knowledge and research is turning over so quickly. Keeping abreast of everything is sometimes difficult when you're an active treating clinician. So it's always enjoyable to speak to others and learn as much as we can. You know, from an athletic medicine standpoint, you know, I appreciate what it takes for athletes to compete at this level. I think, you know, after 40 years of treating elite and pro level athletes, and, you know, working well over 400 high school football games here in the United States. I developed quite an interesting concussion, partly because of dealing with the aftermath of those injuries and realizing it through the years that maybe I didn't do as good a job clinically with my patients and athletes as I should have. So before I get into it too far, just some disclosures I want to make sure that you're aware of. I am a former consultant for Impact Systems. I currently do some consulting with Head Check Health in British Columbia. Of course, SMARTfit. I've been a consultant to Major League Baseball, the Umpire Medical Services for 25 years. And I do have my own consulting company now, Arete Sports Medicine. Today's talk, we're going to talk a little bit with orientation about the SMARTfit Mini with pods. I call this the sports medicine model. The reason I like it so much is because of the adjustable pods. You can fit it into corners for clinics and hospital facilities. Time and space management are always an issue, and this has been an ideal piece of equipment for the clinicians that we've worked with. So I'm a concussion specialist. That's a title that has been derived over the last 15 years of integrating services in the brain injury world with the sports medicine world. Former director of sports medicine and founder of the Concussion Clinic at Casa Colina, which is a very large sports medicine neuro-based hospital rehab center in Pomona, California. I was very honored to work there. Learned so much about dealing with neuro patients. As an athletic trainer and exercise physiologist, never really been exposed to what a neuropsychologist, a neuro-optometrist, a vestibular physical therapist do. And so I got a tremendous amount of respect working with these folks, and most importantly, learning how to case manage these patients and integrate the services so that we can help return our patients and athletes to a high level of function. And you can see some of the other things that I've done in my career there. A lot of it based on the changes in the concussion and sports med industry over the last 10 years, especially with the advent of technology and new devices like SMARTfit. So this is, as Bev said, this is part one. I really want to encourage you to tune into part two as well. Elizabeth McCurry is an occupational therapist that works at Banner Concussion Center. I have to tell you, it's one of the most prestigious facilities in the United States. They do cutting edge work there, and Liz is a huge part of that team. She uses her SMARTfit in a way that is so different from many people, very innovative. So please take the time to tune into part two next week. I know it'll be interesting for you. Okay, so I have some key points and takeaways just from the outset that I wanted to make sure that we cover. One is we're going to review the concussion best practices and the traditional treatment pathways. We're going to discuss the international guidelines, the Berlin guidelines and recommendations. And then I want to introduce you to multitasking as a clinical tool in concussion care. It's more than just a concept, something very real. And as rehab professionals, we always think about integrating the services, but now is an opportunity to do it where it's cost effective, time effective, and it's especially with something that patients really love doing. And I want to emphasize the importance of utilizing the SMARTfit systems with concussion, sports medicine, injury, and rehab. It really encompasses a very wide variety of domains. So if we look at a successful concussion program, what are some of the outcomes that we're looking for and our goals of these programs? So we want to identify, treat, and discharge patients in a timely fashion and in a clinically appropriate manner. Prior to this, I think a lot of times people were getting good neuro rehab, they were getting good vestibular rehab, they were getting good ortho rehab, but there wasn't really an opportunity where people could integrate all those services. So, anytime I'm helping build concussion clinics, team management and team building are essential for great outcomes. We want to decrease that likelihood of prolonged or protracted recovery. That also is really important. Unfortunately for many of you, I think the concussion patients, the TBI, mild TBI patients that you see sometimes come to you a little late, don't they? So you're already trying to catch up on the rehab, trying to get them so that they can return to their activities of daily living, or what I call a normal life. You know, many times people just say, Brian, I just want my life back. So any successful concussion program needs to identify those high-risk patients, immediately, and come up with a plan of care that's going to help diminish the protracted recovery issues. And we want to produce a favorable outcome in terms of referrals into and out of the program, and build the ancillary revenue and treatment pathways for the clinic or hospital. So, you're gonna keep hearing me emphasize this during our talk this morning. The most important person in this process is the patient. And you need to have team members that are all willing to, quote, check their egos just a little bit and look at the big picture, which is, we need to get this person better, okay? So an optimal concussion program does follow some best practices. I had a chance to review your Australian Institute of Sport and your Medical Association guidelines. They are excellent, folks. They've done an excellent job on it. And quite honestly, they mirror very closely to the Berlin International Summit guidelines. Both emphasizing the fact that we have to have measurable data and treatment outcomes. That we're able to track a patient from point of contact. In other words, when that athlete was injured, when that worker was injured, when did that folks, have that slip and fall accident at home? We want to be able to track and document that from the point of entry into our system all the way through the clinical pathway until they're discharged. We should be able to make some recommendations, and we should be able to see what are our predictions for a favorable outcome. And spotting folks that are high risk or that are problematic early on is really important. And we need to have a plan of care in place that's going to allow you to divert those patients to the appropriate clinician in order to help that happen. And of course, the ultimate goal is to prepare the athlete or patient to return to life or return to play. When we look at some of the new trends in concussion care, these are really designed for the outpatient clinic or hospital outpatient facility. Yes, there's inpatient programs, and as you know, they're sometimes they're run in a little different fashion because the patient is there with them. I'm speaking really today about the folks that walk into your clinic or walk into your hospital for care. So we want to use tests that are standardized and understood by all treating staff. And this is where having staff meetings and going through your plan of care, your policies and procedures, in particular with how they relate to concussion care, is understood by all of your treating staff. This does two things. One, it fosters a team approach, and we continue to look at the patient as the most important part. And two, it allows those clinicians that may not be used to working with each other an opportunity to know, okay, I know what Bev is going to do now to treat this patient. I know what the neuropsychologist is going to do. Here's their plan of care. So you can act as a case manager to kind of make sure that referrals are made in a timely fashion, the patient is getting the care they need, and that your treating staff have access, whether it's through your EMR system or however you meet your clinical meetings, we all understand what's going on. One thing I've learned about these patients, I love concussion patients and dealing with them, but they can be very, very difficult to treat. Quite honestly, they've been the biggest challenges I've ever had in my career. Trying to manage what's going on with them, the comorbidities that are involved, and seeing people in a timely fashion, having trust that the athlete or patient is truly being honest with you. Those are all things that are key to success in these programs. I'm in favor of field tests and tests that are very easy, highly reliable, that increase your validity, and that can be done quickly by a multitude of staff. And so if you look at Berlin, if you look at some of your Australian guidelines, talk about impact, VOMS, which is the vestibular ocular motor screening, and the Buffalo treadmill bike test or treadmill test which was designed by Dr. Letty at the University of Buffalo here in the US. And something I'm very high on, developed by one of Liz McQuarrie's associates, Shelley Massengale, who's a neuro-PT at Banner, is the cobalt modified CT-SIB test. It's a balance test that can be done on a platform or on an AirX pad. And essentially it's the CT-SIB with visual motion sensitivity. I've given you some information there on a published article, which I really highly recommend you look into. Cobalt is very easy to administer. The reliability is quite high. And honestly, it will really help you, especially if you're in question about knowing, is it appropriate for this patient or this athlete to return to play? Because they can't trick you on this test. So if we look at VOMS, Cobalt, and the Buffalo, those are all free. There's no charge involved with those. Impact is available at a very low cost, and all three complement the SMARTfit system. So let's talk a little bit specifically about the consensus statement on concussion. The 5th International Conference held in Berlin in 2016, published in 2017. Just some recommendations that they had regarding the baseline testing. You can see them there on my PowerPoint. Testing may be useful, but it is not necessary for interpreting post-injury scores, especially impact. What we mean by that is quite often clinicians will get presented with an athlete that comes to them with no baseline impact testing. One of the great things about impact, even though it's been around for years, is now close to 14 million tests in that database worldwide. So you can have an athlete from the UK or Australia, Canada, the US that comes to you. If you can have their impact data, because of that database, we can extrapolate the information, look at them based on their age paired norms, and move forward. The other thing I want to mention too is if you're using baseline testing, which I am an advocate of, you have to strive to replicate baseline testing conditions when you do your post-injury testing. Okay, it really helps improve your validity and reliability. And neuropsychological testing is the cornerstone of concussion management. Impact, of course, was developed by a neuropsychologist. So, and it's been shown to be used, like I said, worldwide. It's a very high reliability factor. It is not the only neuropsych test out there, but here's why I'm an advocate for the impact test, is that it was designed for athletes. So if we do a comprehensive neuropsych eval on a patient, quite often that could be a 4 to 5 hour test. Impact takes between 20 and 40 minutes to administer. So just want you to keep that in mind. It's specific for the active athletic population, and it's highly reliable. It will complement the other tests that we discussed, Cobalt and VOMS. And something quite interesting with regard to SMARTfit and the applications with SMARTfit is that many of the programs on SMARTfit were derived from visual tracking, cognitive processing, which are two of the domains that are used when you do impact testing. So there's an abundance of information out there on impact. I don't want to go into a whole lot more detail on it, but obviously Berlin is recommending neuropsych testing, and I think it should be important. It's an important part of your arsenal as to looking into how is my patient presenting. Okay, ideally with athletes, if the more baseline information we can get, the easier our job will be. Hopefully they never get hurt, but when they do, it makes our job a lot easier when we have very objective, reliable baseline information. And that's just a picture of the actual paper itself. It's a great read. It's a great read because there's, if you look at the, I call it the lineup. I'm an old baseball guy. If you look at the lineup of researchers, clinicians, active people working in the concussion, the neuroscience, the brain injury, they all attended that summit. Okay. The document's a guide. and is of general nature consistent with the reasonable practice of the healthcare practitioner worldwide. So this is not something that a group of people in the United States got together and developed, or in Europe. This is something that was comprised of a international group of scientists based on best practices. If we had to look across the worldwide population and determine what would be the best tests, what are the best policies and procedures moving forward for our concussion plans of care? That's what these folks put together. So it's organized to follow the 11 R's of sports concussion guidelines. The key component for the athletic trainer or therapist, of course, is sideline removal and evaluation. That's where the highest risk occurs. And of course, the most important caveat for any sideline evaluation is removal from play if we suspect that there's an injury. If you're wondering about what's going on with that athlete, that is not a person that should be out there in an active contact sport situation. Okay, so the 11 R's of concussion management: you recognize, remove, reevaluate, rest, and rehabilitate, which is what most of you folks do. We want to refer, and I don't mean just refer to a physician. I mean making sure that you're referring to a treatment team of licensed healthcare professionals that are specialists in whether it's neuro or vestibular, neuropsych, neurooptometry, which I've learned a tremendous amount working with those folks. Thank goodness I met them, because a lot of the athletes that I was dealing with protracted, prolonged recovery issues ended up having vision related problems. So referral is a big part of it. Recover, return to sport or return to life. And then of course, reconsider. We want to reevaluate and reconsider down the line to see how that person is doing. That's why we do rechecks. We have patients come back into the office to do follow-up, because we know sometimes when left on their own, they can be naughty. So we don't want to have them slip and have that injury resurface. And of course, looking at the residual effects and sequelae, this is where having a physician as a team leader is very important. We want to look to that person for direction when it comes to some of the long-term treatment options for our patients, because ultimately it's all about risk reduction. Okay. We want to return these folks to a high level of play or a high level of function as they return to life. The sideline evaluation, real quickly, we know most concussions occur without loss of consciousness. There's no perfect test right now or marker that clinicians can rely on for an immediate diagnosis of sport-related concussion. The SCAT-5, which I'll talk about a little bit in a few minutes. They also have a child SCAT. Those are great, but they do take a while to administer, and there are some pros and cons to using it. Traditional standard orientation questions regarding time, place, person, these are considered unreliable when compared to memory events and some of the other baseline testing that you may have access to. So the key component for treating someone, sideline evaluation, is rapid screening, things like loss of consciousness, tonic posturing, which if you look in that video of the Australian rules football player, that's what you could tell right off. Balance disturbances that's immediate removal from activity, okay? We want to decrease the chance that that person is going to have a second injury, which is even worse, which brings us into the whole second impact syndrome issue that unfortunately we know can be catastrophic. So the SCAT stands for Sport Concussion Assessment Tool. It's the 5th edition. As I said, there's also a pediatric version. It was developed by the Concussion and Sport group. They are meeting again. I'm assuming there's going to be a SCAT 6 coming up. But I highly encourage you to look at those guidelines, the Berlin Summit guidelines and your Australian guidelines. They're a resource of tremendous information for the clinician. So just to follow up with some last things on Berlin, we want to make sure that all athletes have a clinical neurological assessment, and that should involve things like mental status, cognition, the ocular motor function, sensory motor, gait, vestibular. Also, obviously, pre-season neuropsych testing is incredibly valuable. One of the things that we deal with here in Southern California, we have people that participate outside all the time, lots of club sports, all sorts of things. It's not unusual. I help out a lot of the colleges and universities with their preseason physicals. So it's not unusual for us to have an athlete that comes to us and this just happened to us recently, where, comes in for the football physical and does great until we get to some of the ocular motor function testing and the neuropsych testing. And it's like, well, obviously they're symptomatic. Well, what were you doing? Well, on the weekends, I fight MMA. And so I'm telling you that because we have to rely on our athletes to be honest with us, if someone feels that there's a threat, that they might not be returned to play because of something they tell you, then they're not going to really be forthcoming. So it really reinforces the need to have some baseline testing in place that you understand, that your staff understands, that's trustworthy, reliable, and is valid. It's going to help your medical staff, whether it's your team physician, athletic trainers, who's ever responsible for those athletes or those patients, to make, really important decisions regarding progressing this patient, allowing them to return to play, clearing them to be able to play. So you need to have those tools. So after concussion activity, this is a big issue, and it's one of the things, honestly, early on when I started doing some things with SMARTfit, that I was very, very excited about, because when we get to the point where a patient is stable enough that we can now work with them on return to play, it's an exciting time for them and us. We really want to get that person back. It can be very time consuming if they're doing vestibular over here, balance over here, to be able to combine services, which I'll talk a little bit about in a few minutes, is extremely valuable. But I also want to let you know that there are some contraindications that we need to be very aware of. And I'm sure for a lot of you folks that have been working in the neuro and vestibular, especially in the acute settings, you're aware of those. Positional changes, those are quite common. Sometimes in the athletic population with coaches and physical trainers that are working with people, they forget that, this person had a brain injury. So, I had a recent occurrence where a strength coach was working with an athlete, and granted, the gentleman was a pro athlete, but he'd had a severe concussion and he had a bout of autoregulatory dysfunction. So we need to be very careful initially about what kind of training we do with our patients. This is why tests like Dr. Letty's Buffalo treadmill stress test, or using the Buffalo bike protocol, very important. You should get used to using heart rate monitors. I'm an exercise physiologist, and I trust what I can see physiologically happening with the patient. So the first few days, relative rest, then a gradual increase in activity, ideally starting to integrate and reproduce those specific to life and sport activities. Sub-threshold aerobic exercise that can incorporate some of the ocular, motor, visual, somatosensory. One great thing about that is if they become symptomatic there, are they ready to return? Probably not, right? So this is also a great opportunity for you as clinicians to make sure that you're doing some things in the clinic in a controlled setting, which are going to allow you to determine, what I call the fitness of your patient to return. And like I said, do they each need to be treated separately? Why not use a system that allows the patient to simultaneously work the entire somatosensory, visual, vestibular, cognitive, and functional training range? We haven't had a lot of options previous, but we do have some great options now. So it also makes it a much more efficient use of time for you as therapists. And there's obviously added cost savings on delivery of care, because now the patient doesn't have to impact so many different facets of the care spectrum. So when we look at therapeutic regimen, effective therapeutic regimen, again, outlined by Berlin, but also common sense things that we look at as clinicians after working in this field for a long time. There's a multitude of treatments, and probably the most common with concussion, the clinical presentations are, vestibular, vision, balance, ortho. And the reason I threw autoregulatory dysfunction in there as an exercise, it truly is an exercise contraindication, okay? And presents itself in many different ways. It's important that you start your patients out slow, especially if they have symptoms in these aforementioned areas here. So when you look at these patients, what are we really dealing with? Are they an ortho, neuro, or vestibular patient? I ask folks that all the time that I'm working with. I tell them, raise your hand if this is your patient. Especially in clinics that have the benefit of having all these different disciplines working under one roof. The answer to that question is that one concussion patient might present as all of the above. Okay, so just want you to think about, is there a therapeutic device that allows the patient or athlete to train and rehab in all of the aforementioned domains? So when we look at the vestibular, we know statistically pretty well documented dizziness, 55% of the cases present that way. The visual, 49, balance, 43. Some articles there, excellent article by Dr. Lau, looking at the predictor of protracted recovery with younger athletes in particular that present with dizziness. So vestibular rehab is important. Therapeutic exercise should include seated, standing, eye tracking, coordination, and cognitive processing. Balance, we know the same thing. Normal balance requires the integration of these three sensory systems, vestibular, somatosensory, and vision. And if you don't address those and they're not integrated properly, we get this sensory conflict, this increased risk of frustration for the patient and you as a clinician, because you just treated them, and instead of them feeling better, they actually feel worse, which can have a tremendous impact on compliance and them showing up again for another visit. So we want to make sure that we're training the patient appropriately based upon the symptoms they're presenting with. We want to train them in real life, multitask situations that mimic the return to life skills needed to perform. Vision, the same thing. It's not just about visual acuity. It's about teaming and convergence and divergence issues and eye tracking. And it's one of the things that's quite often missed because we're addressing the cervicogenic issues, the headaches, the balance issues. And quite often we don't realize that this patient is having a vision problem until they're fairly far down the line into their rehab process. So we want to include eye tracking into any therapeutic regimen. Same with the somatosensory. Therapeutic exercise should incorporate challenges to the somatosensory system. That's mirroring life. That's mirroring what they're going to have to do, processing cognitively and reacting to things that present themselves to them on the field, in the pool, in the gym, in life. Vestibular, heavy reliance on vestibular cues during sport and activity. Obviously, as you folks know, controls information about eye and head coordination. And you hear my recurring theme here, therapeutic exercise should provide challenges to the vestibular system. So we've talked about having exercise in an exercise device that addresses all of these different systems, balance, vision, somatosensory, and vestibular. We've identified the need to test, rehab, and train within the brain injured spectrum. Now, what piece of equipment should we consider to deliver that kind of care? So as I mentioned at the onset, this is the SMARTfit Mini with adjustable stands in the pods. It's my favorite piece to work with because it's versatile. Patients love it. I can move it around. I can address all those different issues that the patient's presented with, and they like it. Our compliance rate with our athletes and patients that use it is tremendous because of the gamification involved. They can compete against themselves or others. The other thing about it is that it's different. We can do tasking games, seeking games, spelling, math. There's all sorts of fun stuff we can do on there, which just looks like fun to the patient, but to you as a clinician, it's like I'm actively engaging this patient to cognitively process, to use eye tracking, to cognitively process, to reaction time, in order to facilitate compliance with what the SMARTfit is asking us to do. So it's a really fun device for the patients. And I think as clinicians, rehab professionals, the flexibility that allows you to work within all those different domains at once is really great. It's wonderful. So why it works. Do each of these areas need to be treated separately? We know, especially now from a lot of the pioneering research from Dr. Mike Studer, who's a physical therapist, that these combined treatments help build the neuroplasticity. Why not use a system that allows a patient to simultaneously work within that entire somatosensory visual world, and that's extremely functional. That's the other part of it. It translates quite well to return to life skills, return to work skills, return to sports skills. And it's a more efficient use of time for the clinician, which allows you, from my perspective, I like treating patients. I like working with people. So if it's going to buy me more time to get my hands on patients, to work with them, then I'm in favor of using it. Obviously, that translates into better outcomes, and the patient is truly ready to return to life. It's also the time-sensitive patient care. So I know that you folks are all under pressure to treat more patients and maintain these positive functional outcomes. So, how do we team treat and still ensure that those positive outcomes and return to function, and address that professional overlap issue that I've been alluding to throughout this talk. So SMARTfit allows us to increase the quality time with our patients, promote positive outcomes, decrease that likelihood of protracted recovery, which that is very, very frustrating to deal with. Anything we can do to help identify those issues early on and prevent that is a marvel. Excuse me a minute. Okay, we also want to satisfy the comorbidity of injury issue by testing, treating, which I mean rehab, and training multiple systems at once or separately if desired. And this increases the patient compliance, partly because they flat love it. It's fun to work with. So after activity, after concussion, multitasking during exercise stimulates high-level cognitive activity, promoting brain development. And we know that it enhances all of these factors: visual tracking, processing, all those things. So, excuse me, I want to make sure that I'm directing you to some studies that Dr. Studer has done with SMARTfit on dual tasking. There's some excellent videos available on the website, some great tutorials. I learned a lot listening to him talk. And from a therapist standpoint, I think it's going to be very, very relevant to what you're doing on a daily basis with your patients. So just to encapsulate some of the things that Dr. Studer has mentioned in the tutorial videos and on the papers, SMARTfit helps deliver enhanced cognitive motor training in any and all disciplines, including the PTOT speech. The hospitals that we are using it in, that I've had a chance to go and work with staff, it's really great to see the OT, the PT, and the speech person all working together with the same patient, because they all get that neuroplasticity part. It's the only technology that can scale cognitive demand while concurrently executing a wide variety of physical movements and skills. And the more you work with it, the more you realize this. There's really no top end what you can do to challenge your patients. Okay. Excuse me. Okay. So this last part here, we're going to just talk a little bit about some precautions, contraindications, and considerations. And again, this is I'm putting my exercise physiologist hat on right now. Our what I call our Bible for exercise prescription here in the US is the American College of Sports Medicine's guidelines for exercise testing and prescription. And this is a wonderful resource, deals with all sorts of clinical presentations, not just brain injury and concussion. Also, understanding that we have these physiological events that can occur when we have a regulatory problem, which, as a neuropsychologist friend of mine tells me all the time, Brian, concussion is a failure to regulate. So if we're dealing with a system that's impaired, we do need to be mindful of what's processing that and the physiologic outcomes that occur when we exercise people. So I want you to be aware of the postural orthostatic tachycardia syndrome, or POTS, and of course the autoregulatory dysfunction. So what's the presentation for those? With the autoregulatory dysfunction, it's basically syncope. It can be an irregular heart rate and blood pressure response to the exercise. One of the things that we like to see with an appropriate aerobic exercise program is a linear relationship between heart rate, blood pressure, and workload. Those should all go up very nice. If you have a highly trained athlete and you're watching them and you're not getting a linear response, time to terminate that exercise. So something's going on that needs to be fixed, because these patients can, I call it going south. They can, be in clinical trouble quite quickly. It's very scary for the patient and the clinician, and present as an emergent and life-threatening situation. One of the things, again, that I like about some of the SMARTfit systems is that it does help provide better control and compliance during these early therapeutic bouts. Okay, so want to encourage you to monitor your patients. I always suggest to clinicians that if you're starting on a return to play program or a return to exercise program, that the first 3, 4, 5 workouts, you should be treating them like you would a cardiac patient. Monitor heart rate and blood pressure at rest. Monitor heart rate throughout their exercise session. Monitor their heart rate at termination of exercise, and don't release them until they've come back within the normal range. So, I like a lot of different units. What I care about is, that I'm getting accurate information. So, this Fitbits and some of the Apple Watches, those things are great, but I want something that's actually a heart rate monitor that's pulling right off of that QRS. That's one of the reasons I do use the Apple or the Polar devices. The great thing, again, about using something like a SMARTfit system is that the feedback is immediate and it's auditory. Not only do you hear it, the patient hears it. If they're not compliant or they miss something, you'll hear it beep. So the patients like to compete against themselves and others, which promotes compliance and improvement. I also should have added in there, it also promotes safety. Okay. And so putting the Polar unit on, it's a great teaching tool too, because you can see, hey, look, this is your aerobic zone. This is where you're going to be building your functional capacity. This is where we're actually going to see you start getting in shape and getting more fit. And it allows us to fine tune the programs that we're going to use, whether it's on a bike, treadmill, VersaClimber, whatever you're using in your gym or clinic. Okay, so make sure those initial workouts, you're checking blood pressure and heart rate. Use that heart rate meter. And, contrary to what some people say, it's like they do, you can have a very, very fit looking pro athlete that may need to be treated like a cardiac patient initially. So I just want you to be mindful of some of those contraindications involved. This was an excellent article. I highly recommend that you access it. It essentially, these folks, researchers, went through just about all the new technology that's available on the market right now in the concussion management, whether it's balance and dual tasking and kind of a what's new in the concussion technology world. So didn't have enough time today to really introduce you to all those things, but this is a great article. I highly recommend you access it. There's some great information in there that I think is very relevant to the kinds of patients that you're treating. Other resources for the clinician, of course, the Berlin guidelines. Here in the US, we use the National Athletic Trainers Association, American Physical Therapy Association, American College of Sports Medicine, and of course you folks, your own Australia's own professional resources. Those are the guidelines we want you to follow. As I mentioned before, the SMARTfit website has an abundance of great clinical and research information. The Scientific Advisory Board are some of the top neuro, vestibular physicians, PTs, OTs in the country. There's 2,000 pre-designed training activities, YouTube. There's the website. There's another great source of information is from 360 Neuro Health, which is outstanding vestibular therapist by the name of Bridget Wallace in Austin, Texas. She has an annual concussion summit, which has international speakers. Awesome, awesome, awesome. So the Australian Institute of Sport, here's your some information about your consensus statement. I hope you've all heard of it and are aware of it. If not, there's your website for you. And I just want to say thank you for having me. Thank you, Bev.
Thank you, Brian. So thank you very much for that talk. Appreciate your time and effort in putting that together. So I thought maybe what we could do is just open it up to anybody who has questions.
Sure.
Or comments. Just type it in the question and answer. I'm going to share my screen to give you another example of the SMARTfit system. Sorry, I'll just stop. Sorry, I'll just go to it and then I'll. Anyone has in this video here. Sorry, got a couple of questions. So while I'm getting this together, let's have a little look and see.
Okay.
Can the SMARTfit system be used for more traumatic brain injuries or even stroke contexts? And Rizwan, I would definitely say yes, and that's what we're doing in the clinic here. We use it, I predominantly see traumatic brain injuries and stroke, and we use it consistently for those clients. We have one client who actually got their own SMARTfit mini system for home and is using it for cognitive training with his carers, and he uses it every day for probably twice a day. And this participant had a really hard time with a lot of perseveration, a lot of memory issues, and I just texted his partner the other day and asked how he was going, and she said he's going brilliant, really, really well, and the perseveration and the concentration to daily tasks has improved significantly.
That's great.
Yeah. So I'm going to just show you this one from, and then this just shows you how the SMARTfit system, the mini, can be used in a different context. So if you're not seeing those high professional sports players, but you might be seeing active aging, you might be seeing the cognitive patient, the stroke patient, you can certainly use it. And Rizwan, with the stroke patients who don't have movement in their arm, we use different devices to help assist their arm while they're doing the movement. So it might be a device like this, which we call the active arm. And so then they're moving and they're hitting targets this way. Let me see if there's any other questions here. Yeah, there was a question about the SMARTfit system, whether it's available for hire. We don't do hire because the unit, just the shipping back and forth of the unit and the setup of the unit, it's difficult to do a hire. But typically what we do is we'll take you through a demonstration, and there's the content that SMARTfit have put together to show you how these devices can be used is amazing. Like, there's heaps of content and a lot of videos, so we can take you through those, and we can do a Zoom demonstration to show you. And I've got lots of patient videos that I can also show you as well, that will allow you to see how this device is used in practice.
Yeah, I would just add that, it's been very gratifying to see, Beth, you and I were talking about it before we started, but just to watch somebody start out in an acute setting that's had a TBI, and the way that a lot of our rehab hospitals are using SMARTfit, and then to transition the patient from the acute setting into outpatient, and then on into, return to life kind of things. It's been great. There's a lot of carryover, and the video support that's on there is tremendous. So it's been really good for the clinicians, because we all have a learning curve when it comes to using devices, and clinically what you want to do and the direction you'd like to go with your patients. But having a tool like that where you can go on and watch a 1.5-minute tutorial on, okay, this is how I do tracking, this is how I set it up for seeking, or I can do spelling, or if I just want to do some cognitive games, those kinds of things, it's all there. And I found that to be really, really helpful. And when I've been involved helping doing in-services with our therapists and clinicians, I think the fact that they can use it, multitask it with, and use it in so many different domains, really helps them too on the motivation with the patient wanting to do things and get better as well. Because that gamification, that's sort of inherent in all of us, I think, as humans. We get competitive with ourselves and with others, and that's been a huge factor in patient compliance, I know. So.
Yeah, no, I totally agree. For us, it decreases setup time as well, because everything is, the programs are all there. You can build a program and get them started, and then they do a program for 15-20 minutes. Yes. And no one ever comes back and says, you know what, I did that last time, I don't want to do it again.
Right.
They
may ask you about,
can we do it again?
They may ask you about time, or how many errors they had.
Sorry?
I said, they may ask you about time or how many errors they had, right? Yeah. Which means that they're actually really engaged. You think about that cognitively, they're really processing things to be able to look at it like that. So, fun.
Yeah. Well, I don't think we've got it. Oh, hang on, I've got a couple of more questions here.
Okay.
Let me just go to those. Within the system, how many different games do you have, and how many activities you offer? Gosh, let me, I'm going to allow, there's tons of games. Okay. I would say definitely over 30 different games, and then you can have different levels in each of those different games.
Let's put it this way, a large number.
Oh, yeah. And then the other question is the follow-up webinar. So part 2 of this webinar will happen next Thursday at the same time. So 9 o'clock Australian Eastern Standard Time. So that will be 7 o'clock in Perth, 7 a.m. in Perth. But I want to thank everyone. I want to thank you, Brian, for participating in the webinar, and thank you everyone for joining in, and I look forward to seeing you again next Thursday for part 2. And if you have any questions in the meantime, just feel free to email me at bqi@neurotech.com.au. But again, thank you very much for all your time. Much appreciated.
My pleasure. Thanks for having me.